Welcome, Gyno Curious listeners. I am Dr. Amy Novatt. From both sides of the speculum, we are here to talk about what it means to be a healer and to be healed. Please send any comments or questions to radiofreerhinecliffe.org, and please consider giving the show 5 stars on whatever platform you listen. Today, I want to welcome back Dr. Zoe Weinstein. Zoe is a trained general surgeon, but who now specializes in surgery for benign and malignant breast conditions. She trained at Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx, and currently works for Health Alliance in Kingston, New York. Thank you for joining me again, Zoe.
Oh, thank you for having me.
It's always a pleasure. We don't get to see each other very much, and I was reminded when I got out of my car today and saw you in person how much I adore you.
The feeling is mutual.
Yeah. So we have to unpack some of the statistics that I've been reading about this issue. One, breast cancer diagnosis in women under 50 have been increasing by more than 1.4 to 2% per year over the past 5 years. Women under 40 are nearly 40% more likely to die from breast cancer than women over 40. And lastly, the data and realities of racial disparities are daunting, with Asian American, American Indian, Alaskan Natives, Black and Hispanic women are more likely to develop breast cancer at a younger age than white women. What is going on?
Well, I think the issue is that there are multiple factors that are contributing to this increased breast cancer risk in younger women and women of different ethnicities. And if you read the literature, what the kind of governing bodies who make recommendations, like the United States Preventive Services Task Force, is really asking people to become more interested in starting studies to break down this data in a more specific way. So what we know, for instance, about Black women in the United States is that they are more likely to have these biologically aggressive triple-negative breast cancers. And those cancers have been historically harder to treat. Now, we do have better regimens for those cancers now. We have immune-blocking agents, these drugs you hear advertised on television that are intravenous drugs. The problem is that if patients aren't diagnosed early enough, it is harder to cure them of these more biologically aggressive cancers. These triple-negative breast cancers, as they're called, are often mitigated by genetic mutations. And we know that Black and Hispanic women have been under-tested for these, what are called germline deleterious mutations historically. So there are, in that particular population of African-American women, triple-negative breast cancers, it really could be that we haven't been able to identify these familial patterns of cancer risks that we have identified in white women who historically had greater access to genetic testing and were more broadly represented in these clinical trials that have been going on for 70 years. So we know that's a problem, and we know because of the history of Black people being exploited during testing that there's a reluctance in that community to avail themselves of testing. Now, screening
and science and
research.
Yeah, research.
Yes,
yep.
Research, trials. But some of the research could just be entering your data into a database. And that really has to become more common. Now, in a country where you don't have socialized medicine, it's really difficult to capture this data. So the data is coming from voluntary reporting from hospitals all over the country that report data from their tumor registries. That's not the same thing as capturing the data from every screening center, every hospital, every oncologist, every surgical oncologist, every genetic counselor. It's not the same kind of robust data that you could capture if you had socialized medicine, which makes it difficult to break down some of these changes in incidence in young women and women of different ethnicities.
So thank you. You shared a lot of information, so I want to unpack some of it, but I'm going to just kind of go backwards. So are countries where there is socialized medicine, are data being generated from those countries? Are we learning some information about this younger cohort from places like the Netherlands or England? Any of these countries doing this work?
Well, the difficulty is that we have a more diverse population.
Yeah.
So we can't often glean the same information, say, from the Netherlands, which has a predominantly white population.
Right.
It makes it extremely difficult. So I would say about 10 years ago, there was some data that although Black women continued to do worse from breast cancer treatment, they really couldn't parse out that these women were being undertreated or underdiagnosed. And we were very frustrated by that data because in our day-to-day practice, we really felt that Black women were not being screened as aggressively. And now I think that some of that data is coming to light, that patients are more estranged from routine screening, routine care. Did some of that have to do with the economic downturn? You know, this data is 1999 to 2018, most of this data that shows these worsening outcomes among almost all women of color. The only women who seem to have had a decreased rate of death from breast cancer are white women, but not white women between the ages of 65 and 75. You know, the data is all over the place.
Yeah.
But it's that the numbers are going up and the risk of death in young women is unacceptably high in women of color. Now, some of this has to do probably with behavior and biology. So we know that young women have dense breasts. The Preventive Services Task Force had a recommendation previously that women under the age of 50 did not need annual mammography. And those of us who were practicing at that time were livid. And what we thought was, and you know, I don't really know what the thinking is, but I'm sure it's very scientifically based. It's that you have dense breasts between the ages of 40 and 50.
Unpack dense. What does dense mean? I mean...
Okay, yeah. So it's snowing, and you look out the window. Okay, it's just started to snow. It had snowed the day before, so you made a snowman. The snowman's on the lawn. Now it starts snowing. You can't see that snowman. That's what a mammogram looks like in a woman who's 40 getting her first mammogram. Usually, you're looking at this dense white picture of tissue. That's what the tissue looks like on X-ray.
And that's normal, so to speak.
It's normal. Mm-hmm. It's normal. Now, occasionally you will have a 40-year-old who gets her first mammogram, who had 5 kids and nursed all 5 of them, and happens to have what's called a fatty breast. Because this kind of breast tissue has matured. Why? Because maybe she had her first child at 17. And then had multiple children in succession. And we do think that in some people whose breast tissue is going to behave in this way, that you're going to have maturation of the breast tissue and kind of a senescence of these more going to sleep of these more biologically active cells. So it can happen that you have a 40-year-old who has a very readable mammogram, as we say. It doesn't look like a snowstorm. It looks like a blue sky, and there's your snowman sitting up on the hill. Now, how does that snowman look? Does he look, you know, like a normal rounded snowman, or does he look strange? Does he look like some kind of very angulated white structure? An angulated, funny-looking white structure against a contrast of a blue sky is not a good look for a mammogram. So in that 40-year-old, she may have a cancer on her baseline mammogram. Most 40-year-olds are really going to have a mammogram that looks like a blizzard. And if there's a cancer in there, you may not be able to tell that it's there. So the question is, what do you do about it? Now, in probably about 10 states in this country, a 40-year-old who gets her mammogram gets a letter from the imaging center that says, you have dense breast, and this may decrease the sensitivity of mammography.
I can't tell you how often I have a conversation about this in the office.
That's right,
Women are freaked out.
Right, because New York State is one of those states, Connecticut is one of those states, New Jersey. And you know what? That's not really plain English language.
No, it is not.
No, it doesn't really clarify anything. But if the patient reads that, and they have already seen their gynecologist or their primary care physician or their nurse practitioner, they may not see that person for a year. So they saw the person on January 1st. They had their mammogram on January 20th. They're not going to see them to the next year. Do you think they're going to remember to bring up this question? What did this letter mean? No.
Or they've called the office 5 times, can't get through, can't get to their doctor. And this is the morass of, the medical world in today's.
Exactly. Yeah. Now, this could be solved by a trigger that would indicate a bilateral breast ultrasound for people with dense breast tissue. The problem with that is that when you have an ultrasound, as many people know who've had an ultrasound of anything, the breast, the abdomen, the neck, it's technician dependent. You're in a room with someone who has to go through whatever tissue they're assigned to examine. When you, as an ultrasound technician, are assigned to examine the neck, you're looking for, say, 10 things, okay? 2 veins, 2 arteries, the thyroid gland. There are other things they're looking for. When you're looking through a breast of a person who's an A cup, or a breast of a person who has a D, E, F cup, that person may miss some areas of the breast tissue. So we know that ultrasound can't be used in a general way as a screening test for all women. Just on the face of it, it can't be done. What else could you use? You could use a breast MRI. A breast MRI is a very expensive test. It involves getting an IV, getting a contrast injection of gadolinium. What do we know about these 2 tests? We know that they find things that are usually benign.
They call that a false positive.
Yes, and then a patient has to have a biopsy. Now, this all sounds extremely cumbersome, stressful, expensive. But if you're a 45-year-old who shows up with a breast mass, who's been getting mammograms for 5 years with dense breasts, and has a cancer of the breast and cancer in the lymph nodes, we are pretty sure, depending on the biology of that tumor, that cancer's been there all these years.
Yeah.
So all of this bean counting that we think the U.S. Preventive Services Task Force is doing, and it's not just bean counting about expense, it's about anxiety, it's about overtreatment of certain benign diseases. They decided 10 years ago when they had their last statement that it wasn't worth it for women between 40 and 50 with dense breasts to get a mammogram. Now that we have data that we have an increased rate of cancer in young women and a worse outcome in those women, now they're, I would say, backpedaling. So now they're saying they recommend baseline mammography at 40, but then they're recommending screening every 2 years with mammography. Now, if you're the person in the office treating someone who has one of these biologically aggressive cancers that's already in their lymph nodes, and they missed a year of screening, which happens to me every week in my office, and the patients will tell you their doctor said that they only needed a study every other year. So no one is wrong and no one is at fault, but now you have a patient with lymph node positive breast cancer, which is harder to treat. Or you have a patient with one of these more biologically aggressive cancers that has to be treated with intravenous chemotherapy and intravenous targeted therapy because of tumor size. One of the things we know about accurate screening is that we find cancers earlier. So we're trying to decrease the burden of treatment on patients. Now, if people do just as well clinically when they get these aggressive treatments, if the tumor's half an inch or an inch, it's still more of a burden for the patient to undergo these aggressive treatments. So we're having a hard time figuring out how to interact with these general federal recommendations and what we see in real-world practice every day. Now, aside from the breast density making it difficult to identify a cancer, there's probably something about women who have persistent dense breasts through the course of their lives after menopause into menopause that increases their breast cancer risk. Why is that? Because the patients whose breast tissue undergoes fatty replacement are women whose cells are really going to sleep. they are not as biologically active. When you look at a mammogram in a 75-year-old and it still looks just like the mammogram of the 41-year-old you saw a half an hour before, you know that on some level that patient may have an increased breast cancer risk. It's not just that it's harder to pick up the cancer and she may need an additional study. It's that there's something biologically going on in that breast tissue. So as people live longer, you don't want to discount the importance of screening. Breast cancer risk increases as we age, so you can't discount a 75-year-old. That person who gets a letter from the imaging center that says she has dense breasts needs to talk to her provider about getting a breast ultrasound or a breast MRI. The other contributing factor, of course, to breast density can address these two populations, young women and older women, is the use of hormones. So we know that since people have changed their behavior, right, and women are not having as many children, not having children,
having them later
in life, they may be using birth control pills. They're using them earlier because they're getting their periods earlier than they did 50 years ago. They're using them longer, and they're having fewer children, so they're spending less time off of hormones. And there's definitely a relationship between birth control pill use and breast cancer. But how do you address this when you have female children that you don't want to get pregnant as a parent, as a partner, whatever the question is? It's extremely difficult. For me, it becomes less difficult for women in their 40s. Women between the ages of 40 and 50 who are having an increased rate of breast cancer incidence and poor outcome really need to think twice about their method of contraception. And I find that this is a topic that is not addressed, especially, no offense, Amy, among gynecologists, because I think that it's very difficult to go through menopause. I'm 61. I never even considered the use of hormone replacement therapy because I've spent my whole career telling people they couldn't take it. I think it would have made me feel better. I think it would have made me look younger. But I thought it would be hypocritical to take it myself and tell all these women they can't take it. So I didn't take it, and it's not fun. There are all kinds of problems related to menopause. There are cognitive problems. There are psychiatric problems. There are sexual problems. There are self-perception problems. I mean, it goes on and on. But if you're seeing these patients every day as a gynecologist and you have a 45-year-old who's on birth control pills who feels fine, why would you want to upset the apple cart?
I think you're pointing out something so important for the audience to hear. That because in this country, and perhaps in many countries, our medical system is so fragmented that, at one time the family doctor kind of took care of everything, and they really knew globally what was going on with that woman and often about that woman's family. So there was a much more, a broader sense of who somebody was and their medical risks and medical conditions, right? Now, you go to your gynecologist, and yes, you're right. I see the woman who comes in and says, my vagina hurts. I cannot have penetrative sex. Do something about it. I'm not sleeping at night. I'm having hot flushes every 20 minutes, et cetera, et cetera. And what are you left with? You're left with a number of different approaches. Then there are many, but hormones is one of them. Or you're right, the person who's been on birth control pills for 25 years, feels great on them, is saying to me in the office, Amy, I do not want to go off them. Life is good right now. Do not ask me to go off of them. And I've had people say that to me. And then again, also, the data for us is also confusing. So there's plenty of science that's looked at the relationship between birth control pills and breast cancer, hormone replacement therapy and breast cancer. And I'm telling you, this data changes episodically. Yes, no, yes, no. And, then of course you're looking at the person who's suffering in front of you, and you see this cohort of breast cancer diagnoses, survivors, people who passed from it. And I'm looking at this other cohort. So
and your cohort is bigger than my cohort. That's why it makes it harder for the person who's kind of at the front lines, like a family practice doctor and a gynecologist, to make a de facto negative recommendation against prolonged birth control pill use from 45 to 50, or a brief course of hormone replacement therapy. Now, you could try to figure out who's at risk for developing breast cancer, but, this year I had a 27-year-old on birth control pills with a gigantic breast cancer.
Oh, gracious.
With no family history. So, when you read these recommendations from the U.S. Preventive Services Task Force, they're trying to get you to figure out, identify increased risk. But we know that most new cases of breast cancer are in patients that we can't really identify a risk for breast cancer. So it becomes very difficult for the people on the front lines to really take a position against these drugs.
Yeah. And then, of course, we have that group of women who I see first who say, I had a mammogram that suggests there might be something wrong, but, I have 3 friends who had biopsies and nothing was wrong. And then they had all this pain and suffering associated with this test. And there's all this false positives out there. And that's another difficult conversation because, if you speak to a woman who's been diagnosed with breast cancer, she says, I'm so grateful. The mammogram helped me. The biopsy helped me. I'm on my way to healing and recovery. And then you have this, the next patient I see says, I'm not going to go for that biopsy. I hear it really hurts and I'm scared. And I'm saying this with great empathy. I get it. Medicine can be very, very invasive, right, Zoe?
Yes.
It's tough sometimes.
Yes, every time I tell a patient that they need a biopsy of, say, something like calcifications of the breast that's seen on mammography, I have to tell them that 80% of the time the biopsy is benign. And, they have the choice. They don't have to have the biopsy. The problem is also because I've gotten older and I've been doing this for so long, there really have been times where patients decline a biopsy and then we're following something on mammography for usually 2 years, every 6 months, and then it's stable. But you know what? It's just a stable cancer. And in the 3rd year, the patient has a serious problem.
Can we unpack that? Because stable cancer, that's kind of paradoxical.
So what happens is that there are changes in the breast that aren't a mass, or they don't change that quickly. So you can have an abnormality on imaging that just stays the same because it's a slow-growing cancer, and it doesn't really look that different to me or the radiologist. The patient thinks they're getting away with not having a biopsy, and in the 3rd year they have, say, an ulcer on their nipple because what they had was, a low-grade precancerous change in the ducts, and now it's become something more serious. And in reality, in patients like that, and this has happened probably not that often, 2 times in 10 years, the patient probably had cancer in their ducts that was a more biologically aggressive variant over time because these cells change. I mean, that's what cancers do. The cells undergo biological changes. So not to scare people, but not having a biopsy is sometimes just not as straightforward. So we do tend, as medical people tend to minimize the downside. I mean, I think that if you're a person who's a chest surgeon who has to biopsy a lung nodule in the operating room, I don't think those people downplay how dangerous that is. But, the breast is a skin appendage. It's hanging off your body. It's a lot easier to biopsy that. And you would know that because of treating people with ovarian cancer and uterine cancer. You can't biopsy an ovary. You have to take the thing out.
Yep.
So we're kind of lucky that we have access to this organ that even though these biopsies can be painful and you can have trauma and it can be stressful, it's really safer than a lot of these more invasive biopsies.
Yeah. Can you talk to me about, because you've mentioned it a couple of times, this kind of biologically active phenomenon. Could you explain that to the audience, please?
So I think people are aware of these genes, the BRCA1 and 2 genes, the BRCA genes.
Mm-hmm.
And, when we say that African American women have these triple negative breast cancers, they don't always have these BRCA genes, but the BRCA1 patients often have these triple negative breast cancers. And what that means is that there really isn't a good target on the cancer cell to get rid of the cancer. And so that these cancers are traditionally treated with very aggressive anti-chemotherapeutic regimens.
So kind of, we don't really know what's going to change the cancer or get rid of the cancer, so we kind of bomb them with everything.
So that's what we used to do. So essentially what you're doing is you're just killing all rapidly dividing cells, because that's really what you think a triple negative breast cancer is.
And triple negative is?
That the cancer cell has no estrogen receptors, it has no progesterone receptor, and it doesn't have this HER2 protein that's in the wall of the cell. Now, interestingly, when we talk about hormones increasing the risk of cancer, and we think that hormone pills that you take are really stimulating these hormone receptors in breast cells and causing cancer to evolve, we know that even though these triple negative breast cancers without estrogen receptors, even though those cells don't seem to respond to estrogen, they are still triggered by hormonal changes. So we know that in patients who have these BRCA mutations, that early pregnancy can be a big trigger for developing the breast cancer, whereas for everybody else without a genetic mutation, an early pregnancy is protective against breast cancer.
Oh, so confusing.
Yes, it's very confusing. Now we have targeted therapies for, they're called checkpoint inhibitors, immune blocking agents that work better for triple negative breast cancers. But you have to be a certain stage to be able to get these drug regimens. So if you show up with a relatively small triple negative breast cancer, you can't get these very effective regimens. You may be able to in the future, because we still need trials to see whether they are safe and effective in patients with small tumors. For now, we give them to patients with big tumors or tumors that have already traveled to their lymph nodes. And those patients seem to have a very good response.
Okay. So we've talked a lot of science thus far. Let's pivot a little bit. So for women listening to this, they're freaking out a little bit right now.
Absolutely.
And I understand it. There's, two of us with breasts and another person in the room who is of male identified body also with breasts, which we're going to come to. But so what can women do? You've mentioned screening, so I think we need to just reiterate when they should start screening. What about some modifiable risk factors? So let's say obesity, for example, is a risk factor for breast cancer. Let's talk about what those risks are and then how women might modify it, because we're only in so much control of our bodies, but what can women do to promote health and well-being?
All right, so we could talk about the risk factors for breast cancer. They're getting your period early. You can't control that. Okay.
And that's about estrogen.
That's
Hormones again.
Right. So if you talk to your grandmother who's 90, and if you take histories from women all day, a 90-year-old will tell you she got her period at 16 for the most part. If you take a history from a 35-year-old, she's going to tell you she got her period between the ages of 9 and 12. It's a given, okay? So you can't control that because you're 50 now, so you couldn't have moved the needle on that, all right? What about late menopause? Menopause after 55 or older. You can't do anything about that. I mean, you could have surgery, but we don't recommend that people have surgical menopause to decrease breast cancer risk unless they have a known genetic mutation, right? You can't do anything about your breast density. That's who you are. You could have dense breasts at 40. You could have them at 80. You're just not going to know until you go through menopause. Can you decrease your use of birth control pills? Absolutely. But do you want to get pregnant at 21 when you have 3 jobs, or you're in college, or you're raising your 3 kids? So, you could. If you lived in a really equal society, men would take some responsibility for birth control. There are patients who say their husbands will never have a vasectomy. You have a 42-year-old, okay? Her mother had breast cancer at 45. She has dense breasts. She's using birth control pills. And you say, listen, this is really not in your best interest. Did you ever talk to your husband about having a vasectomy? She has 3 kids, no more kids. She says he won't do it.
Well, just to remind everyone out there are other forms of contraception for female bodies as well. So you're pointing out something really important. If you are of that age group, cohort, have risk factors, or just curious about what are my birth control pills potentially doing to my breasts, remember there are non-hormonal IUDs.
Yes.
There are other approaches. But yeah, we only wish that penis havers would take more responsibility.
Yes, I think it's very important. I think you've spent your whole life as a woman negotiating pregnancy, fertility. If you're in a relationship with someone and it's really a truly equal relationship, it would be nice if that person gave my patient a break from this very important concern.
Yep.
So, exogenous hormones, meaning hormones you're taking from the pharmacy. We don't really know about these bioidentical hormones that people are using. I would say that any patient who's getting these compounded estrogens and progesterones from a compounding pharmacy and rubbing them into their skin, and they're my age and they come to an appointment and they look 10 years younger than me and they feel great, they're definitely getting what we call a systemic effect from those drugs. If they went through menopause and they started feeling badly and they started using these drugs that we are not federally regulated and we don't know how much absorption they have, and they started feeling better and they don't want to go off them, I would say they're having a pretty good result. So we don't want people to use those if they have an increased cancer risk.
Let me just clarify that. So bioidentical hormones are often a treatment that women going through the perimenopause or menopause will request in my office. And there's kind of I'm going to call it almost a mythology out there that bioidentical hormones, which are biologically equal to what's in our bodies, are safer than the hormones that are made by big pharma that have an extra double bond or an extra methyl group or whatever allows them to be, owned by big pharma. But I always say to women, listen, I don't know whether that's right or wrong. There's not enough data to help me to give you any real information because bioidentical hormones are not really studied because big pharma doesn't own them, and so nobody's doing the research. So it's very confusing. What Zoe's pointed out is that everybody kind of absorbs these hormones differently. They're often given through the skin, and in fact, if anybody's on hormones, the best way to get them is topically, and that's a whole nother conversation. But again, there's nobody out there, Susan, what was her name? Summers. There's a number of, and there's a lot of books written about this. And I have to admit, I will prescribe bioidentical hormones. So I'm not saying absolutely no, but you don't know if they're safe. I always say I am going to treat them as having the same risks, perhaps the same benefits as big pharma HRT.
Yes.
And that's the best I can do.
Yes. So now what's interesting is that we definitely think that the increased rate of breast cancer among young women is related to obesity.
Let's talk about that, please.
Okay. But the problem is that the data we have is that obesity increases the risk of breast cancer for postmenopausal women. Now, why would that be? It's because there's a feedback loop of hormone production between functioning ovaries and the brain, and you know that, right? Mm-hmm. Now, when you're postmenopausal and you're obese, all of these fat cells make chemical messengers that have the ability to change certain molecules into estrogens that stimulate your breast tissue. We don't think that that's supposed to be happening as much in premenopausal women who shouldn't be relying on these fat cells to make hormones because there's a very active feedback loop between the functioning ovaries and the brain.
Let me just interrupt you. So what Zoe is saying is that when we're young, our ovary's doing the job. It's putting out estrogen. It's putting out progesterone. It's responsible for testosterone.
Yes.
The ovary and the brain are saying, hey, you have a period. So everything's kind of working well. But then we go through this thing called the menopause, and the ovary is quiescent. It's no longer making these hormones in any way the rate at which it used to. So if you are carrying extra weight, guess what? You can get estrogen from these fat cells and the activity in those fat cells.
Yes.
Keep going.
So what I really think, because I really do think that the data is behind, the data is not... The data about obesity and cancer risk and the biology of obesity and cancer risk really hasn't been studied enough. So, for instance, I personally think that if we performed biopsies of these fat deposits in obese premenopausal women, we might be able, and postmenopausal women, we might be able to start seeing some difference in the biology of the fat. Now, they did just publish a study about the different kinds of fat between people who were not just women, but who were obese and exercised, and people who were the same size and did not exercise. And we know that these fat cells are responding to stimulation, all kinds of stimulation of hormones, insulin, glucose molecules. It's just straight up biology. But we know that the fat of people who exercise is less biologically active in a bad way than the fat in someone who doesn't exercise.
Whoa.
So that is another, these are two different parts, two sides of the same coin, obesity and exercise. So we know that 150 to 180 minutes a week of exercise decreases cancer risk, period, not just breast cancer risk.
Right.
And we know that obesity in postmenopausal women is an increased cancer risk. And I think that if you have an understanding that many of these cancers that are increased in young people, they're not just breast cancer, they're also lymphomas, colorectal carcinoma, gynecologic cancers, they must have some relationship to obesity and just your own hormonal milieu. And now we're not just talking about estrogens and progesterones, we're talking about insulin, we're talking about people's ability to metabolize all of these processed foods that we're eating. We find that people maintain their weight and have healthier fat who eat a whole foods diet, even if they're at the same weight as someone else who eats more processed food. So I think that right now in society in the United States, you are seeing an explosion of obesity, inactivity, the consumption of processed food, the use of hormones. It's like a conflagration of all of these risk factors. And I personally think it's going to be harder to reduce these risks for people who are disenfranchised, people who are poor, people who live in communities without access to healthy food, people who are so financially stressed because of the cost of living. You can't ask these people to go for a walk every day. You can't ask them to buy organic food.
People who have no access to radio stations that are talking about this issue. I mean, it sounds ridiculous, but there are people who are in information deserts.
Yes.
And who are isolated, who don't listen to podcasts, who don't get information about breast cancer risk, so they don't even know.
Yes, I mean, this recent statement from the U.S. Preventive Services Task Force says that up until the 1980s, 20% of women between the ages of, say, 20 and 55 were obese, and now it's 38%. That is an outrageous number.
Yeah. Yeah. I mean, we've talked about obesity on this show so many times from so many perspectives. And what's true, perhaps one of the only truths, is that there are so many reasons why people might be carrying extra weight, whether it's biology, it's lifestyle, it's lack of activity, et cetera, et cetera, et cetera. So Zoe and I are not suggesting this is an easy thing to solve, but at the same time, if there's one modifiable risk factor for breast cancer early and late, is to eat better as best as you can, even if it's one small change. Oh, I'm not going to eat Doritos, but I'm going to, find something else that's, I don't know,
baked ruffles.
Okay. There you go. There are often alternatives, and sometimes they are just as inexpensive and just as salty and crunchy. So really doing your best to eat well, to exercise, move your body. We are becoming so sedentary in front of these microphones, these computers, our cell phones. Move your body.
Yes.
Yeah.
And also, these injectable drugs that are associated with weight loss are definitely going to move the needle on cancer risk. They are definitely going to lower cancer risk. What the long-term outcomes are, can you stay on them forever? I just don't know if anyone has the answer to that.
No.
But it's certainly better than having an operation to bariatric surgery, weight loss operations that we know do not result in a durable weight loss outcome. So as a person who's seen so many of my cancer patients have surgery for weight loss and gain back all of their weight, I am a little bit encouraged that some of these drugs may help them get over a hurdle. It is very alarming to have a breast cancer patient. Now remember, all breast cancer outcomes are worse as women gain weight. It's like a straight line up a graph. So when you have a patient who's 45 and you put them into menopause, and since there's a significant risk of weight gain with acute menopause, and then you have a young breast cancer survivor who's gaining 10 pounds at every 6-month visit, it is very worrisome that you've treated someone with surgery, chemotherapy, radiation, anti-estrogen therapy, and this other needle. You are not moving the needle on that because you can't mitigate whatever is going on hormonally, personally, that's leading to their weight gain.
Just to unpack that a little bit, what Zoe's saying is some of the treatments that we give, or many of the treatments that we give for breast cancer to these young women, make them menopausal chemically. And then we know that so many women in the menopause gain weight, and we don't completely understand that relationship. We just don't. So you're getting rid of one problem, but increasing another risk. So I want to pivot again. And we touched on it briefly, and I just want to point out, because I think for so many young women, they're not thinking about breast cancer, and it's okay. There's only so much we want to be afraid of in our lives on a daily basis. But, breast cancer is the most common form of cancer in women who are pregnant and who have recently given birth. It occurs about once in every 3,000 pregnancies. So I guess briefly, are we talking about hormones, and we're talking about women having pregnancies later in life? So it's all of these, again, these factors that maybe didn't exist 50 years ago?
What's interesting is that we've always known that there's a relationship between pregnancy and breast cancer. So exactly as you describe, around the time of pregnancy, a year after you've given birth, you have an increased risk of breast cancer because of this hormonal stimulation. You've made these hormones yourself, and the cells are dividing in your breasts because you're getting ready to nurse. And so women who have a breast mass during pregnancy or during nursing or in the year or 2 years after giving birth really need to have that mass investigated. Now, of course, if you're 48 and people have told you that's not too late to have a child and you're going through in vitro fertilization, yes, your breast cancer risk is increased. Again, this is a problem with medicine that isn't socialized. These are usually for-profit practice groups. They are not required to share their data, right? So we don't really know what the true incidence is of breast cancer in people receiving fertility treatments. And that is a problem.
Yeah. So just to kind of wrap this part of our conversation up, because I want to make sure we pivot to people who are transitioning. And I guess the conclusion is, one, I'm sorry to say that us vulva havers are at risk for breast cancer even young.
Yes.
2, that the recommendations around screening, mammograms, ultrasounds, MRIs, it's confusing out there. Don't think you're alone in saying, what the fuck am I doing here? We are all, even as practitioners, we go back and forth around what the recommendations are on a pretty regular basis. But I think what Zoe's pointing out, I know what Zoe's pointing out is, please demand screening. 3, if your breast feels funky to you, don't assume it's because you're nursing. Don't assume it's because, I'm gaining weight or I've lost weight or, that new bra is pressing my breast in a certain way. Get it checked out, because unfortunately, youth does not protect you necessarily. If you're a woman of color, and we're talking about not just African American women, but Native women, Asian women, I mean, really anyone who's outside that spectrum of Caucasian needs to, as best as it is possible, seek care, seek information. don't make assumptions about, what you don't need or what you need. Please try to find ways of getting care and getting information because you are at risk. Did I summarize okay?
Yes. I mean, I think we should just say that women should start having mammography at 40 and have it every year. And if you have dense breasts, you have to talk to someone about whether you should have an additional study. If there is a family history of cancer in people under the age of 50 in your family, you may need to start screening before then. If you think there's a familial pattern of cancer, people with ovarian cancer, uterine cancer, colon cancer, and you think you could be someone with a genetic mutation, you need to talk to your healthcare provider about that. So this is a lot more to put on the individual in terms of advocating for themselves. But without real standardization of care, access to care, that's really what we're left with.
Yeah. Yeah. Oh, it's sobering. It's really very sobering. So I want to make this pivot. So, cisgender women are easily the largest gender demographic affected by breast cancer. But transgender men, trans women, and non-binary people, along with cisgender men, can also develop this disease. So just some statistics, because I love statistics. Less than 1% of all breast cancers occur in men. Black men have the highest incidence of male breast cancer and death, and that the average lifetime risk of a man getting breast cancer is less than 1%. In 2024, researchers estimated that about 2,790 new cases of invasive breast cancer will be diagnosed in men, and about 530 men will die from breast cancer. So these are small numbers compared to, millions and billions, but it's still very significant. But when I was looking at information regarding trans folks, there's not a lot out there.
No, there isn't.
And, in my cynicism, I assume that part of it was just the social stigma, the fact that medicine is not caught up with kind of the social movements of the day. There's so much prejudice out there on so many levels, just against women in general, but certainly people who are transitioning. There's so little access to great medical care for this group of people. So what would you say? I guess first, are you seeing some trans folks in your office?
I see trans patients. I see mostly, I would say, trans women who are having breast pain, breast masses from hormonal stimulation, people who are undergoing imaging for these problems. The standard response is that we don't have enough data. We're just not collecting the data.
Yeah.
And we don't have enough long-term data. But if you extrapolate the data from the use of hormone replacement therapy and birth control pills, stimulation of the breast tissue density, I think that we should all be concerned that our trans women have an increased risk of breast cancer, and that we have to be aware that any mass in that patient population needs to be investigated like any mass in cis women, period. Yeah. End of discussion. And I think the general recommendation is that you should be more concerned after 5 years of prolonged hormone exposure. And that's kind of what we have for women who receive hormone replacement therapy after menopause. So I think we're using that as a jumping off point, and it seems reasonable. The patient population I really am going to have a harder time taking care of, and I haven't seen very many of these patients, are trans men because they have often had top surgery.
That's right.
And that leads to scarring. And then if they're in the early postoperative period and they have what we call nodularity of the chest wall, as we might see in a patient who's had a mastectomy, a cis woman who's had a mastectomy, who has just a scar across the chest wall, it's very hard to figure out what's going on there. So I personally think that for the time being, the physicians who are performing the top surgery, which I don't do because I'm a cancer surgeon, really need to figure out a meaningful way of following this patient population because many breast cancers have testosterone receptors. And if you're giving your trans patient testosterone, you have to be concerned that a nodule on the chest wall could be a breast cancer, because patients who have mastectomies for breast cancer, cis women, can have chest wall recurrence because even though you have that tissue removed, there's often microscopic breast tissue there. Now, when does this problem present? It can present decades after you have top surgery or mastectomy. So this is definitely going to be a long-term concern. And again, I know that countries that have socialized medicine are having problems now that they didn't have when I was young with the same problems we're having, not enough providers, complexity of medical care, an aging population. They're having all these problems. But again, if we don't have a central registry, we're really not going to learn enough about these medical concerns in a forward-thinking fashion, which would be very useful for this patient population, because you would like to be able to say, we don't have guidance in 2024, but now that it's 2030, we have 10 years of data and we have guidance.
But you're not suggesting that those who are taking testosterone, including cis men who are full of testosterone,
or not
should
so
they...
much.
Finally, a little humor in this very serious, challenging conversation.
Sorry.
Thank you. No, thank you. Everybody needs to laugh because we have to laugh.
Too bad we have to laugh at men, though. Sorry. We'll talk about that prejudice another time. Zoe, you're not suggesting that these folks have mammograms, are you? Oh, now who are we talking about?
I'm sorry. Let's talk about cis men first.
Okay.
Should they be having mammograms?
Cis men who have a family history of breast cancer in first-degree relatives, their child, their sister, their mother, probably need to have a mammogram. Important.
That's right. No one's talking about it.
Because what we're describing really is we're describing a man who has a risk factor for a deleterious germline mutation, like a BRCA1 or
genetics.
Yeah.
We're not talking hormones right now. Right. Specifically, we're talking about genetics.
So, most men, when they have breast cancer, present with a mass behind the nipple because that's where their glandular tissue is. So it isn't really that hard to figure out if they have a cancer. What you're really trying to do is identify the population of men that really have an increased breast cancer risk. Those patients could undergo a breast exam like a woman would every year with their primary care physician, and we recommend that together with a screening mammogram.
Okay. And again, I just want to make sure it's clear for trans men, we're not necessarily saying mammograms. We're saying that, unfortunately, there's very little data out there. We don't know about the use of testosterone long term. What would you suggest?
Well, look, if you've had top surgery, you can't have a mammogram because
right.
There's nothing there. You should have a chest wall exam every year
because
we know that, first of all, chances are 100% right. They're trying to leave your nipple areolar complex, right? So there are definitely ductal cells behind the nipple there.
Right.
You have a chance of having residual breast tissue there because that operation isn't done to be a definitive cancer operation like a mastectomy,
That's
right?
right. It's not the same surgery. Thank you.
So you definitely need a chest wall exam every year, as though you had breasts. And I actually don't really know how that patient population feels about that, but it's better for their health.
Yeah.
And so they can have a mammogram. Now, should trans women have a mammogram? I don't think we have any guidance on that.
Yeah.
And what about trans men who haven't had a mastectomy? They definitely need a mammogram because, first of all, they have the same risk of breast cancer as cis women, right? And they may have more if they're using testosterone because we don't want people to get the idea that estrogen is the only bad molecule in this conversation.
That's right. Thank you for clarifying that. So we're coming to a close, and this is heavy stuff out there, and I wish we could make it lighter and easier to kind of hold on to all this information. It's complex, it's confusing, it's scary, it's really scary, and it's a beautiful day out in the Mid-Hudson Valley, so I guess I would say to all of us, take moments and make sure that you're experiencing joy and pleasure and laughter and love, because one, we don't know what's going to take us down in the end,
No.
right? It could be breast cancer. It could be, I don't know, a comet, but that there's room for joy too.
Yes, and just being outside, you don't have to live up here. We were talking before about how, some of us grew up in the city.
Right.
You could just walk down your block in the city and look at that one maple tree on your block right in the middle of the cement, losing its leaves. And we know that these small parts of nature in the urban setting really make a difference for people. The birds on your fire escape, just to connect with things that are bigger than yourself.
Moreover, there's science that's showing us that music and dance increase our endorphins, improve our well-being. So we have access to these things no matter where we live, no matter who we are. Just dance. So with that all in mind, Zoe, what are you going to do today for yourself that gives you pleasure?
I'm going to pick up my sewing machine from the repair shop.
Sewing. I didn't know that you sew.
I have that book, Sewing for Dummies.
Right. That's right.
Really?
That's right.
Like, you can't read it in public when you're a surgeon, That's what I'm going to do.
I'm so glad. I can't thank you enough for joining me again on Gyno Curious.
Thank you for having me.
Yeah. And thank you to my producers and the Epicurean, and thank you to the audience who just inspires me. And I wish you all well. Please listen to your instincts and your intuitions. They are the greatest of teachers, not to be ignored.